I'm imagining a couple additional people will join us as this progresses. So I am Bethany Lilly. I am the Senior Director of Income Policy at the ARC of the United States, and I have dragged two of my colleagues along to help me kind of lead a discussion about federal LTSS reform. I know there's a state LTSS reform panel happening at the same time, so thank you all for joining us for this one. I'm really excited that we're getting recordings of the panels after everything. Judy and Namati, do you want to introduce yourselves so that folks have an idea of who you are, and then I'll share some slides and we can get started?
Sure. I'm Judy Fader. I am a professor and former dean of the McCourt School of Public Policy at Georgetown University, and here to be as a partner in crime with Bethany.
Most definitely. And hi, everyone. I'm Namati Mansaray. I'm a Senior Policy and Government Affairs Manager at Caring Across Generations, and I'm looking forward to this discussion.
And on that point, we would like this to be more of a discussion. So if you want to go on camera and you want to contribute and jump in whenever you feel comfortable doing so, please feel free. I know the Academy was aiming to have these workshops be a little bit more interactive, and so that's very much how I structured this one, and hopefully we'll have some success with that. But let me share just a basic set of slides that I pulled together that hopefully will spark a discussion around long-term services and supports. There we go. And let me there we go. So I think the first question that I wanted to throw out to the group are around, I know many people have heard many different terms over the years. There's long-term care, which is what I used as the title of the section, because I think that's what's been used the longest. But there's also long-term services and supports, and I think that's the preferred language now. Certainly in the disability space, that's what we preferred to use. So what are long-term services and supports? I borrowed this from the National Governors Association because governors actually do quite a bit of the work providing long-term services and supports in this country because they run the Medicaid program. So I like to default to their definitions. But on that, I think three questions that always come to mind with me in terms of defining LTSS are kind of what are concrete examples of LTSS? And I think big ones that come to mind to me are nursing homes, other long-term care facilities. For people with intellectual and developmental disabilities, who are the people I represent, that includes intermediate care facilities. That also includes some larger congregate settings. For people with serious mental illness, who I used to represent, that would include long-term psychiatric hospitalization. It would also include all the community services that people with disabilities rely on. And I think that's a piece that has not always been the focus, especially in the aging space, around kind of what community options are available. Are there other examples you two can think of or you would think we should discuss with regards to LTSS?
I agree with you. I think when we think of LTSS, we always think first of congregate care settings. And then also, in terms of like home health aides and the long-term care that they provide underneath that umbrella.
And Bethany, I would just add that I think that there has been over the years increasing attentions. Most of my work, as you know, has been with respect to the needs of older people. And I think that the mix of services needed in the community gains now a great deal of attention. I've worked with advocates in a couple of states who have focused a great deal on transportation in that regard, and the barriers to both participating in the community and getting needed services if a transportation is not available as it should be under Medicaid. So I think that the needs of the communities are aligned in this respect.
I always think of transportation when I think of HIV care in North Carolina, as strange as that sounds, because it was hard for my clients when I worked at an HIV clinic there to get to their doctor appointment from wherever they happen to be living. So transportation is a good one, really good example here.
Yeah.
And I think we've kind of touched on all the different populations, which was going to be my second question. Who are the folks that need long-term services and supports? Older adults, people with disabilities. I would also say caregivers, and I think that's a piece that maybe has become more highlighted over the past couple of years. In terms of, I think we often don't think about LTSS as a caregiving support, but it really is. Because it basically takes the place of unpaid family caregiving a lot of the time.
That's, or what the research will tell you is that it doesn't, family members don't go away, but they are able to, the burdens on them can be reduced, and they are able to focus their engagement on services that they feel better equipped to provide. Some of the hands-on care, and in some cases even medically related services that families have been increasingly expected to do are not those that they feel most comfortable with. So it's no question that it's relief and support, and enables them to remain engaged family members as opposed to providing what ought to be provided by perhaps others with more skill.
Right. And in some cases, I feel like it could take off some of that burden, like the financial burden. You know, family caregivers are unpaid, and they're a lot of that support that they're giving to their loved ones is coming out of their pockets. So being able to have long-term services and supports is also contributing to their own economic and
Absolutely.
And I think that leads very neatly into kind of like what the repercussions of not having LTSS are. That you end up with a lot of burden shifting to people with disabilities and older adults themselves, to their families, to other programs. And I always think of, you know, the fact that my grandmother had to move into a nursing home because we couldn't find a home health aide in her, you know, tiny little rural town in Iowa. And that's, you know, I think it also increases the burden on the system to some degree if you don't have access to the right kinds of LTSS when people need them. Anyone else who's on the, oh, go ahead.
Oh, no, I was just going to say, just to add on to your point, you may not need, you know, a full-time home health aide or assistant, but you may need, you know, a part-time one. So having those supports in place will go a long way to helping the person receiving care, and then also the person that's providing care.
It's also, I think, important to mention here the consequences for the beneficiaries or the people who need services themselves, because we have lots of evidence that of getting inadequate care. And so it's not simply that burdens or that the responsibility for caregiving falls to others, it's that people don't get what they need.
Definitely. Are there other folks who are on the line who might want to contribute something to any of these three questions?
And you can also use the chat function if you don't necessarily want to speak up, if you wanted to just add your question there, and we're happy to read them.
Yep. Not to force anyone to join the discussion, but. Well, so the next element of this, which I think, you know, stems from how we think about LTSS and solutions that we can build at the federal level. Who's paying for LTSS right now? And I do greatly appreciate the Kaiser Family Foundation, because they always have very pretty charts of all of their infographics. But this is certainly the experience that we at the ARC have in terms of our population of people with intellectual and developmental disabilities, that the vast majority of funding is Medicaid. And then there's some limited other public funding. And then there's an extensive amount of out-of-pocket spending. Private insurance is a tiny fraction of all of this. And I know there's been some degree of interest in private and long-term disability insurance over the course of history, kind of legislatively and otherwise. And that's something we might get into when I have a slide on all the different proposals that have been proposed over the years. But I think when I look at this and I think about the cost of LTSS, I think a lot about how much burden we're putting on the public service system. Because Medicaid is effectively the only payer by and large for a lot of this. And so we have, I think we have a program that is going to be under a lot of stress in the coming years, because we know, and I think the original citation I had for this was the Long-Term Care Commission report that Judy was on a couple of years ago, for the number of older people with LTSS needs that we're going to have over the coming years is just going to continue to grow. And in the disability space, we're very, very pleased by the increased life expectancy that many people with disabilities are having. But that also means that the degree of costs for long-term care are going to keep growing. And so I think, for me at least, when we talk about LTSS reform, the biggest question I have is, how can we ease the burden on the public system? And then what are other elements of the system that we need to build? And this goes to something that the ARC and Caring Across Generations has worked very closely together on, which is the infrastructure of care, which looks not just at LTSS, but also looks at paid leave, which is an element here that I think we really need to be thinking about. And I want to focus and specifically name the fact that direct care workers are the backbone of this entire system. And since they are primarily paid by Medicaid, they are dramatically underpaid. The average wage across the US right now is just over $11 an hour. And so when we think about the workforce, we also need to think about making sure that that workforce has a living wage. And so when I think about the costs of LTSS, I do think about the costs on families, and we talked about that a little bit too, but I think the most about kind of, how do we build a better system here?
Yeah, and I'll just throw out a few stats. And so at Caring Across Generations, we really focus on older adults, people with disabilities, the care workforce, and family caregivers as a care collective, care unit. And so, 7 out of 10 people will need long-term care after they turn 65. More than 90% of people are not insured for long-term care, and most families must make severe financial sacrifices, and many impoverish themselves to pay for essential care that they need. So the cost of not having this, not having LTSS and HCBS is really just too high of a burden. So that's why this is something that we definitely need.
And Bethany, I would just add to or make a friendly amendment to your comments. I think it's that what's concerning is the stress on the current public systems rather than the stress on public systems, because I think I know Joanne Lana's on the call, and she and others are, including myself, are advocates for social insurance for long-term services and supports, and which would mean that we would have a broader and more secure base of funding to meet existing and growing needs. Yeah. So the problem is not the currentness, the problem is the underfunding of the system. As my long-term colleague, Harriet Commissar, I'm going to paraphrase her, I don't know if she said it exactly this way, but there is no cheaper system than one that relies on unpaid family members and underpaid workers to provide inadequate care. So.
Yep. No, and I think that's kind of why I wanted to have this discussion today as part of the NASI conference, because the Academy studies social insurance, and that's certainly how a lot of the state programs are looking at this, as a social insurance model. And I think, historically, that's also how Congress has looked at it. And maybe what we should do is, I'm realizing I should have organized these slides differently. But,
oh, no, you do. I think you, yeah. Well, I'm enjoying the conversation.
Oh, good. So one other kind of preliminary point that I wanted to make was around how it's the very big difference in how people with disabilities and older adults use LTSS. And I think this is something that the disability rights movement hasn't done enough to explain. And so I always like to include it in my remarks. Is if you look at this, you'll see that over 80% of the care that people with disabilities receive is predominantly community-based care. That has been the result of decades of advocacy from elders in the community and from folks that came before those of us with disabilities now advocating today, who have pushed for expanding community-based care. And that has not been the case in the aging community to the same degree. And I think this particular infographic really clearly articulates how that dynamic has played out, and how I also think it contributes to how people with disabilities think about the system a little bit differently than people who are advocates for older adults or who are older adults themselves. And that goes to home and community-based services, which is something that have come up several times, but like just so folks have a baseline definition. Home and community-based services are services that help people in the community rather than in a congregate care setting. And so it might be medication management, it might be assistance getting in and out of bed if you use a wheelchair, it might be some type of employment support if you have an intellectual or developmental disability and you need some help figuring out how to get to your job or figuring out how your job works. Medicaid covers a huge spectrum of home and community-based services for people with all different kinds of disabilities. And there's a lot of overlap with what older adults need to, and Medicaid also covers a lot of home care services for people with older adults and for people with disabilities. Some common terms that might get thrown around: personal care attendants, who help people with kind of that day-to-day physical disability related issues. You also have direct support professionals who tend to do the more services for people with intellectual or developmental disabilities, so tend to help more with the cognitive side of things. And then you also have other kinds of mixed mental health services, some of which are through the Medicaid rehab program, some of which are through other programs. And so that's my definition of home and community-based services.
I just wanted to note, and I think it's come up with the work we do at Caring Across Generations, but also like how HCBS is used in different ways. So I think of how, you know, there are many people with disabilities who use, who need access to home and community-based services because they want to remain independent. And I think that's something that, you know, that we need to talk about more. It's not just having care, but it's also, you know, because you want to be independent in your homes and in your communities.
Maybe you don't want to live with your parents anymore. Maybe you want to have your own apartment and, you know, be able to, and maybe your parents also don't want you to live with them anymore. we should admit that it's both ways. But, you know, I think the independence and the civil rights aspect of it is really important. And one thing that I think has really changed over the past year in the context of HCBS and long-term services and supports generally is that the pandemic has really highlighted how dangerous a lot of congregate care facilities can be. A little over 1/3 of deaths from COVID have occurred in congregate care settings. I mentioned this in my early panel, but I still can't get over this fact that they had to call the National Guard into a long-term care facility for people with disabilities in Illinois because over half of the facility had been, both residents and service providers had been infected. And I think that creates a particularly unique moment to focus on home and community-based services reform as part of long-term services and supports reform.
Bethany, you've got a couple of people have asked questions in the chat.
Let's see. Sorry, since I'm sharing my screen, I don't always see this chat. Let's pull this up. Oh.
I'm happy to read it to you if it's easier.
Yeah, if you wouldn't mind. I can't seem to get the.
Okay, so Marianne Cowan, would you like to ask your question yourself? Marianne asked if we could review the barriers to long-term care insurance funded by commercial insurance versus social insurance, and the barriers to adding help at home to Medicare.
Sure.
Thank you, Judy.
Oh, where are you? I can't see you, Marianne. There. So I'm happy to take on the private long-term care insurance question, Marianne, if that's useful to you.
Thank you.
Yeah, my last line I've often used is that the private long-term care insurance industry has been a fledgling industry since I was a fledgling. Thank you for laughing, Bethany. It's a mixed blessing that you laugh, but that's a long time. The reality is that the companies have not, that business has, that industry has never found a way to create a truly viable business model that enables them to collect premiums, to support, to make available insurance over decades. It's different than from annual insurance. And as a result of the difficulties that they have faced, fewer of them are operating today than operated when I think the high point was probably in the 90s. Most of them, there are very few left, insurance companies left in the business. And the way they attempted to be viable was, although there was a mix at the beginning, some of it, just as in private health insurance, was really not worth the name insurance. They were not really at all good products. I would say that what's happened, the way the industry has tried to sell something that is affordable and has some value, but only some value, is essentially to limit the dollars they provide. So they moved mostly away from actually ensuring the sizable expenses that face people who need a lot of care over a lot of years, and moved it to a limited dollar amount that would work for, say, a couple of years, which does cover the needs of many, but leaves those with the greatest needs unprotected. So they really have left that business, that responsibility. They've just limited their ability in order to sell a lower priced product, and still it is not picked up at the extent, even estimates of what people could afford, or they're not buying to that level. And it's partly an issue. Some point to understanding and education and confusion about what Medicare will do for them. But an awful lot of it is that it is not a reliable product, and not only in terms of its benefits, but in terms of the premiums that you're going to face, the premium increases you can face over time. So for the large part, the industry has recognized it can't do that. The people in the industry have recognized they can't do the job. And you add the barriers to adding, that would be a home care benefit, an LTSS benefit to Medicare. Is that what you were referring to? Yeah, I think I can save that for Bethany. I
was just going to say, I'm happy to move to the next slide, because I think that one of the major proposals on that exact point has been Representative Pallone put out a discussion draft. Judy can correct me on this.
Yeah, it's a couple years ago. Yeah.
That was a proposal to add a limited LTSS benefit to Medicare. And I think that's certainly one proposal that folks have certainly circled around. I mean, I was working with the Consortium for Citizens with Disabilities LTSS task force at that point on our comments on that. And I think it was how you structure the benefit will have a lot to do with who will take advantage of it. And this is one of the interesting things about Pallone's proposal was we thought it was a great idea, but we didn't think it was going to help a lot of people with disabilities, because the limited number of hours that were being authorized aren't going to be what many people with disabilities need. It will help a lot of seniors, maybe not as things progress, but kind of early on in the progression of aging. If you can get a couple of hours of home healthcare aid, you could slow potentially. I mean, we don't have an extensive amount of research on this, at least to my knowledge, although Judy might know more about kind of how much we could slow the curve in terms of folks ending up in nursing homes or in other kind of more intensive care settings. But I certainly think that's a proposal that's been floating around. And I think when Pallone put out that discussion draft, he got a lot more interest than he was expecting.
That's a good thing.
Yeah, exactly. Do you have any thoughts on that proposal, Judy?
I think that just specifically on it, the proposal was to provide a limited amount of funding. It was dollars, cash benefits for home and community-based services after a waiting period. and which means that people would be on their own for either to take care of expenses on their own to manage their needs for a period that varied. Pologne's was a 2-year period. The proposal we originally put out would have had the waiting period vary by income. And but then to provide these home and community-based services as a Medicare benefit. That is what Mr. Pologne would like. And it was for people who qualified based on functional needs, limitations regardless of age. So trying to keep the constituencies together. I think, Bethany, your concerns about the limited benefit are entirely valid. And the both, from my perspective, that was an idea that I put before that long-term care commission. But the after class had been repealed. And so it was a conservative design. It was meant to, when Mark Cohen and I developed it more fully, it was designed to recognize a space for people using their own resources, personal responsibility for private long-term care insurance, but with a strong public role. And the limitations are, there are many limitations to it. Right. So it's, but it was, we regarded it as something that perhaps could generate the kind of interest it has. And now if we can do better than that, that's great. But you also, I think that you also had a question here that I know that we are all interested in, is improving HCBS coverage in Medicaid.
Yeah. And I think that's the last 3 proposals here. So the ARC and a collection of other disability groups, including the Autistic Self-Advocacy Network and a few other folks, after the fight to repeal the Affordable Care Act in 2017, did the rounds around healthcare reform and broader healthcare reform, and pointed out that historically Medicare for All, a proposal that generally Senator Sanders champions in the House, and then Rep. Jayapal has been in lead on in the House for several years now, did not include HCBS. And that was something that we really pushed them on. We haven't endorsed Medicare for All, but it's a little disingenuous to call it for all if it doesn't cover HCBS or LTSS. And both of those bills now, in fact, include LTSS. Well, Senator Sanders' bill includes HCBS access, and the House version includes complete LTSS access. And then there was also a proposal from DeLauros that was a slightly different take on expanding to universal health coverage in the US, and that proposal also covered HCBS. And I think one of the things we thought this was important here was making sure that the kind of baseline was any type of healthcare reform must address LTSS access. And partly that's because Judy alluded to this, and I put this on the slide because I thought it was important. Historically, we had the Class Act, which was passed as part of Obamacare, which would have done as Judy said, a public-private partnership to expand access to LTSS kind of through an opt-in buy program. Unfortunately, it was repealed because it was found to be financially unviable. But I think it's really interesting to kind of line up all of these different proposals, because to the question in the chat about expanding HCBS access, the ARC has always supported, and I think from the beginning of our existence as an organization, making HCBS mandatory. And because right now in the Medicaid program, certain LTSS services, institutional LTSS services, are by and large mandatory. There are some that aren't, that are more optional. It gets complicated. But by and large, they're mostly mandatory, whereas HCBS services are completely optional. States can choose to cover them or not cover them, which leaves people on waiting lists. And we have over 800,000 people across this country right now on waiting lists for HCBS services. So I certainly think that's an excellent step in the right direction. But I do want to flag also that there's been an extensive amount of state work in this space. And in fact, Washington State passed something that is very similar to the Pologne long-term care services and supports addition, which is a cash benefit that you pay into. a social insurance model. You pay in, you then receive benefits afterwards. It's a limited amount of cash. So to my point about people with disabilities, I don't think it's going to be quite as cover them in quite the same way that we would like necessarily. But that is definitely something where there is interest in that more social insurance model that Judy mentioned. And there's also action being considered. And as I mentioned at the top, and I just for those of you who weren't here at the top, there are also there's currently another workshop session on kind of additional states that are taking a look at not just LTSS, but the broader family care concept, but are looking at types of social insurance at the state level. Also flagged that Hawaii has actually had a kind of a home care benefit for quite a few years. I've heard mixed reviews of how well it works for folks, but it is on the books. And so I think that's, you know, there are states that are very interested in expanding this in the social insurance space. And so I think that creates a certain amount of interest in a more Pallone style, you know, kind of Part E to Medicare. And I will say, I don't think that having an HCBS benefit expansion in Medicaid and adding a Part E to Medicare that covers home care are at all contradictory. I think they'd actually be very complementary proposals.
And that was intended.
Yeah.
Or recognized that nothing, that particularly given the limits to the benefits that you were talking about in the Pallone proposal, that you need a strong Medicaid to take care of, to essentially provide the foundation for people with limited resources. There's no question.
Yeah.
I think Joanne might have a comment on HCBS in New York. Do you want to speak your comment, Joanne, or do you want me to read it for you?
And also another question before that, I think Dorothy had a question.
Sure.
Yeah.
Anyone want to take the Biden proposal one? I haven't looked at that in a few months.
No, well, no, okay, because I was going to ask if people, maybe there's somebody on the call who knows. So Biden definitely took, highlighted the concern about waiting lists in the campaign and committed a sum to a dollar sum that is not enough to address services, to expand HCBS. That was part of the campaign. In general, I think that since his election, that the administration has certainly been advised by many that waiting lists are are an indicator of problem, not the problem in and of itself, and that what's needed is an entitlement. And Joanne is quite right that New York provides services to people who need them, albeit through, unfortunately, in my view, through managed care arrangements, which might lessen some of the availability. But that aside, what's needed is an entitlement to HCBS in Medicaid. So I don't know what's happening with the rescue package and what funding is in the rescue package, whether any of that money got in it, or the bump to, which may not have been Biden's proposal, but I think it's consistent with his concern, is the bump in the federal matching funds for HCBS. Bethany, can you say more about those things? Yeah.
I think Namate probably can too.
Yeah, I was going to add that there is a bump. It was a 7.35 percentage point increase. So that made it pass the House, and it also made it into the Senate version. So, I mean, it's evident that HCBS is definitely important. And hopefully that stays on and it'll be passed. But yeah, Bethany, if you wanted to speak more to that.
Oh, I think that was all I was going to say, just that we made it in finally. This is something that the community's been advocating for since the beginning of the pandemic, because, and I think this kind of gets to Joanne's concern, which is that the quality of HCBS services nowadays is not always the best. And oftentimes people face hours cuts. I have heard a lot about the assessments process in New York and how people get their hours cut very regularly. And I think that's one element of, the So the bump is an increase to the federal matching percentage in Medicaid. And that means that this money will be going to HCBS services. It will be extra federal money. So states can, we would hope, use the other money to continue to invest in HCBS services and perhaps raise wages for direct care workers or take other steps. The legislation also had, I don't remember where it ended up because there was a lot of discussion about bird rule and what couldn't be included.
You mean how much direction of the funding could be put in? Yeah.
But I think, my understanding is we were pleased where everything came out, and I think this is going to be incredibly helpful funding. So I think, kind of going forward, it will be very interesting to see kind of what the proposals are, and kind of where everything goes. I was really pleased to see the president supporting the FMAP bump, because to Judy's point, I think it's getting at the exact same problem. And so I think it'll be very interesting to see that. So I'm going to close the screen share. There we go. So are there other questions folks have for us? Or other thoughts that you think we should be thinking about in terms of long-term care reform?
I had to miss the first 15 or 20 minutes, so ignore me if you've already been over this land. But it seems that we really need a way to get much more fundamental reforms before the public. That people, I mean, it still is the case that more than a third of Americans think that Medicare already covers long-term care. I mean, the degree of misunderstanding is just rife. So major education endeavors, sending out information with every Medicare explanation of benefits, kind of blanketing. I mean, if I see one more movie in which the way people die is to be killed, I mean, it seems like the only way we can make movies these days is to take pills or be suffocated by a pillow. Whereas almost everybody actually just lives out their life. And we can't even stand to tell that story. We've got to increase the wages of the direct care workers. I mean, that's just outrageous. We have to really engineer much more voluntary help, the villages kinds of things, so that a whole lot of things are done off budget, including in poor areas and rich areas, because it simply can't come on the budget. So, yeah, but it seems that there's very little will to deal with the sort of more fundamental reforms. We've been working on just trying to get data for counties as to how just elder care works, because there's at least data in elder care. It's very hard to get good data for everybody who is in need of disability services in a county when you count everybody. But at least for the elderly, there's some data. And we have actually, if anybody wants to try it out, it's eldercaredata.org. You can see any county you want. For the first 30 or 40 data elements, we have 1,000, but we've put 30 or 40 up for tryouts. But to get people to think in terms of, well, everybody pulls from the same well on Meals on Wheels, on disability supported transportation, on the workforce. So, shouldn't there be some way to see if there are serious deficits and maybe even to address them? But every other country has some coordinating entity. And at best, we've got the Area Agency on Aging and the Public Health Office and the hospitals and 22 other entities or 1,000 other entities in some areas, none of which actually communicate with each other or see the deficits. So yeah, it seems that we need to find a way to get to that one level deeper that would have us come out of the pandemic really with a majorly changed set of priorities. What do you think?
I mean, I do think that that's one of the things that I'd hope we would get out of the pandemic, because I think we've seen heartbreaking stories about how congregate care settings have resulted in massive outbreaks. And so I don't know if it's going to be, to your point, the kind of awareness of what Medicare and Medicaid cover and how that's different. But I do think there's going to be more of awareness that like what folks want. And this is actually something that AARP has spent a lot of time surveying folks on. And it's very clear that older adults and people with disabilities alike would prefer to live in their own homes and get support in their own homes. But that the system hasn't kind of come along with that. So I think that point maybe is getting more public awareness. I don't know if it's the kind of, and I don't know that it needs to be the wonky policy of what program covers what services, so much as it can be, you know, this is what I want. I don't really care how we do it. Just figure it out and get me what I want, you know?
I wonder if at some point there isn't something of a split in the availability. I mean, this is very controversial, and I understand that. It's even controversial between lobes of my own brain. But you know, the 30-year-old person with serious brain injury or intellectual disability or whatever, I would do almost anything to have that person live in whatever way is rewarding to them. I mean, that to have a decent shot at being in the community and in the world. But I think that we probably need to expect that people my age, I'm hitting almost 70, ought to be moving into more manageable homes. We should not be expecting that we're going to support single elderly women in 4-bedroom houses in the suburbs. That, that the public endeavor should expect a certain amount of acquiescence to disability and old age. Again, I mean, I'm not entirely sure that I go for this, but boy, I tell you, when I go doing home visits to people who are in houses way too big for them to keep up, and then recognize that in Washington, D.C., here where I live, we have 1% of the available housing available to somebody in a wheelchair. Now, a good deal more has to be built, but it doesn't have to be rented to the people who need it. So we have all this housing that no one can reasonably use. No one with any substantial physical disability can reasonably use. And we have to remember that almost half of us who make it to 85 are going to have serious cognitive failure. So living alone with cognitive failure poses a lot of challenges. So shouldn't we have developed lots of appealing home-like alternatives that allow people to live with, when they're still able to walk and still able to get around and still recognize something of who they are, but that we aren't trying to do 24-hour day care to my 96-year-old mother. So, but we haven't even had the conversation about this.
I just, as a disability rights person, that raises a whole bunch of red flags for me.
Sure.
Because, it's someone's functional needs should not define their life experience. And I would actually push back really hard on any type of age-related distinction there. Because I think everybody should be entitled to live the kind of lives they want to live. But I think we have a couple more questions. But yeah, I'm happy to let Judy or Namati respond if they would like.
I'm with you, Bethany.
Judy and I have an arrangement that we have to fix whatever we're going to fix before Judy needs it. So this is
and I'm older than Joanne. I'm almost 74. So we got to hurry.
Hey, we've still got 15 years or so, Judy.
Well, my plan is, my husband's and my plan is we're going to live to 120 and then drop dead. And live healthily.
Guess what? That is a really unreasonable plan.
That you say that, and that's why we need insurance. That is really
exactly.
correct. So we can
work hard on the insurance front. There is a question here about that the pay is outrageous, but if we actually increase the pay,
Yeah,
it's
I
gonna
was
be-
going to address that.
Yeah.
Yeah, I was going to address that. And if you want
Go
me
for
to.
it.
I also, I wanted, yeah, that, and when I said insurance, I mean social insurance, just to be clear. All right, so the confusion was that won't, if we pay workers better, won't it increase costs? And what I would say to you is that the concern on underpayment here is really on the Medicaid side in large part. And so that is not coming out of people's pockets. That is something that we are publicly supporting. And so yes, it would increase costs, but I think there is a values question as to whether the way to make something affordable is to underpay the people who deliver it. That feels to me like a moral quandary, or something that is
Washington-
immoral.
In
Yeah.
Washington, D.C., I was the head of Cancer and Chronic Disease Bureau for a period of time. And I was struck that now, every area may have its own problems, but just to illuminate one, Washington, D.C. at the time had 60 home care agencies, every one of which had to serve every home in D.C. So, Washington has lots of small apartment buildings. Imagine that there's one with 6 Medicaid eligible recipients who need personal care. And it is likely that they have 6 different agencies. Every agency requires a 3.5-hour minimum. And so most of those folks would get 2 different aides, one in the morning, one in the evening. So you have 12 people involved in taking care of the people in that little apartment building. It turned out that if we change to the kind of approach that is commonplace in Scandinavia, where the home care agencies are geographic, you would save almost half of the Medicaid dollar and double the pay of the 4 aides that you needed to have in that home. Now that does reduce maybe the number of aides, but the number of people coming at us in old age is so large that I don't think that we would have a problem if we doubled the income of home health aides and had them move around so that within one building, someone was 45 minutes with Mrs. Jones and then 45 minutes with Mrs. Smith. And then, and everybody had her phone. And so if something came up, they could call for that person. We have the mirage that having all 60 home care agencies competing somehow assures quality and efficiency. And against all evidence that that's true. I mean, there's no evidence that that works. Every single agency requires a 3.5-hour minimum. And so, I think that there are things we could do that would increase efficiencies enough to bring people up to a reasonable living wage and benefits.
Yeah, Joanne, I would take issue, and I think we've got some other questions too. I would just take issue with not with your very well argued case that there are efficiencies. We need so much more care. We got to spend more money. So I think anybody, just saying.
Well, and I think that goes to exactly what the next question is, which is there is a growing shortage of care professionals. And there is a growing shortage of care professionals because we don't pay them well and they don't have benefits.
And they don't have career ladders.
Exactly. All of which the questioner is asking about, and there are proposals, I think many to that effect, and I suspect we would endorse them. So you're on the right track.
So Namati, did you want to add anything on the care professional side? And then I can do one more question.
You guys have definitely covered it. It's important that we maintain retention, because as our aging population is getting older, they're going to require more long-term care, long-term services and support. So making sure that they do have those benefits like paid leave, like childcare, making sure they do have a living wage so they can support themselves and their families while taking care of other people is really important. So making sure that those things are in place so that people do see them as careers that they want to, have now and then have in the future, so that they can take care of our community. So I think it's really important that we make sure that that we have those supports in place. I think there was another question from Dorothy about, do you think there is anything policymakers can do to improve the private long-term care insurance viability?
I can take that. Dorothy, it's a challenge. And I will tell you that the thinking that behind the Pallone proposal was that, which was based on work I did with my colleague Mark Cohen at the University of Massachusetts in Boston. It was based on the concept that having a public program that would take care of expenses at the tail end after a waiting period would provide actually a foundation for private long-term care insurance to be perceived as doing what it tries to do now, is to fill that gap. And that waiting period, that it is a limited benefit, and that marketing them together in perhaps in ways that Joanne is talking about, to make clear what people can expect and why it is that they would need these kinds of services. That plus some other changes, and I can, if you send me an email, I'll send you just some specific proposals that Mark and colleagues have made elsewhere to improve the viability and reliability of private long-term care insurance. That said, I don't think the industry themselves think they're the answer to this problem. So whether they can be a piece of a solution is worth exploring. But based on my experience of going on 50 years, I'd say we need that public program.
Yeah, fair point. I mean, my question comes from the fact that it's hard to imagine that the public program could be adequately funded to do everything we need. So I was trying to think about, sort of in the evolution of the industry, what is.
You're right, Dorothy, you're on the right track. Essentially, that they could provide they could fill in, they can provide the extra. And even more important to me, because it's lower income people, that's why you have to have Medicaid.
Yeah.
I'm putting up Judy's paper. I'm sort of in Judy's shadow.
Go ahead.
But I have been working with the long-term care insurance companies, who are mostly actually life insurance companies. It's interesting that they are not the companies offering Medigap or any other health insurance kind of thing. But Genworth has come out in favor of Judy's proposal so long ago. The Association of Life Insurance is now really working on it. I have 2 or 3 papers of, kind of how you're going to do this and how you're going to do that, which is showing quite some engagement. We need to update what Judy did 7 years ago at some point, but there is something of a fire growing under the proposal that she and Mark Cohen and Melissa Favreau published, and I put the paper up there.
Thank you.
I think that the problem is that it's no one's top agenda, that every substantial policy-making force from pharma through healthcare, through insurance companies, has something that is a higher agenda. And so it's, I call it the Cal Ripken of the world, shows up everywhere, does its job, but never is, kind of in the limelight. And so we need to, if we want to have this happen, we have to push it up to somebody's, pushing agenda. I've talked now with 120 people over the last year, one-on-one, and everyone but one says that this is the right policy and you don't have a chance in hell that it would get through.
I would take issue with that, just because I think, we here at the ARC and with Caring Across Generations with Judy, we're working on this. We want to see this type of reform. And to Judy's point earlier, this is something President Biden has articulated that it needs to be a fix. And so I think, especially given the pandemic, we're at an opportunity where we can look at systemic reform for the first time. And
I'm with you.
you know, and I also think just in terms of trend lines and the number of older adults that we're going to be having coming into our system with greater needs over the next few decades, we don't have a choice. We're just going to need so much more care. We're going to have to invest. And we're
Amen.
going to need paid leave.
There are people using the Exxon stations in Fairfax County, the richest county, one of the richest counties in the country, who are 85 years old women living in cars. And we are not shocked. We are not responding. So let's figure out how to get people angry. So that there's the motivation to get
Yeah, I was going to say, thank you everybody for coming. We really appreciate it. And thank you to both of my co-speakers. I really appreciate you both making the time. And yeah, thank you. Thank you all.
Thank you, Bethany.
Take care.
Bye, everybody.
Bye.